Hi, hello. My name is Enrique Ocio from the University Hospital Marqués de Valdecilla in Santander in Spain. I will present you in 5 to 7 minutes the results I presented at last EHA meeting about the combination of Linvoseltamab+Carfilzomib in relapsed refractory multiple myeloma patients. These are my disclosures. And well, we know that bispecific antibodies are a good option for current myeloma patients, and linvoseltamab is one of these BCMA-CD3 bispecific monoclonal antibodies that was recently approved in the EU for patients after 3 or more prior lines of therapy based on the results of the LINKER-MM2 study. It resulted in an overall response rate of 71% and median PFS not reached at 21.3 months of follow-up. The LINKER-MM2 is a multi-cohort study evaluating the combination of LINVO with several other established and investigational anti-myeloma therapies. And here I will present the data of LINVO in combination with carfilzomib in this LINKER-MM2 study. This is the study design of the trial. These were patients that were relapsed refractory myeloma patients after 3 or more prior lines of therapy, or more than 2 if they were triple class exposed or double class refractory. They could have received prior carfilzomib if more than 6 months has elapsed after the last dose. A first cycle was given with linvoseltamab monotherapy with a step-up dosing and then a weekly administration. And then after cycle 4, it could be switched to every other week administration of LINVO. And carfilzomib was started after this first cycle 0. So from cycle 1, carfilzomib was started at the usual dose, but it could be switched to weekly 70 milligrams square meter or lower after cycle 2 of treatment. The primary endpoints is safety, and the key secondary endpoints were efficacy, as you can see here. These are the patient disposition. We can see that there were a high number of patients that were older than 75 years old, and if we focus on the refractoriness, 50% of the patients, half of them, were refractory to proteasome inhibitors, the majority of them to bortezomib. 43% of them were triple class refractory. Regarding the safety, the primary endpoint, there were 17 patients DLT evaluable, and only one of them had a DLT, that was a thrombocytopenia, a grade 4 thrombocytopenia during tumor lysis syndrome that completely resolved. The duration of exposure to the different agents was similar and also only changed in the different cohorts based on the different follow-ups. There were 2 patients that discontinued linvoseltamab during treatment that was due to a septic shock and also respiratory insufficiency. There were other patients that also discontinued carfilzomib, and I don't think it was anything really that came up as very important. Regarding treatment emergent adverse events, hematological toxicity was the usual with this combination. We have, in terms of non-hematological adverse events, the most frequent one was CRS in 70%, 60% of the patients, diarrhea in 52%, asthenia, nausea and vomiting, and pyrexia. Importantly, we have to know the infections in this combination with LINVO plus carfilzomib. There were 90% of the patients with infections. The more important ones were CMV viremia or COVID-19 or upper respiratory tract infections. But if we focus on those patients that with a grade 3 or higher adverse events or infections, there were 43% of them, and the majority of these patients had any kind of respiratory infection, pneumonia, bronchitis, so in different terms, but 43% of them approximately had this grade 3 or higher. CRS, most of them occurred in the cycle 0, so with linvoseltamab monotherapy, and there were no grade 3 or higher CRS. One patient had an ICANS in the context of the grade 2 CRS and also resolved very quickly. We also have to know the cardiac adverse events. There were 5 patients with any cardiac adverse events or issues. 2 were grade 3 or higher, 2 cardiac failure, one of them resolved, and the other one was an older patient with some pre-existing cardiac toxicity, and he passed away because of that. But we did not see any significant key finding in terms of these cardiac adverse events. What about toxicity? Efficacy, sorry. We have efficacy, we are around 90% of the patients had an overall response, 76% CR or better. But if we focus on the two first cohorts of patients with 150 milligrams of dose of linvoseltamab with enough follow-up, as you can see here, practically all of them had an overall response, and all of these responders have a CR or better. So I would say that virtually all patients with enough follow-up achieved a CR in this patient population. The 12-month duration of response rate was 87%, and the PFS at these 12 months was 83%. In the evaluable patients with MRD, 71% were MRD negative. And finally, this is the swimmer plot of responses for the 19 patients that responded. You can see that the majority of them are still on treatment. 13 of them are still on treatment, which is this green arrow here. Only one of them had discontinued due to progression, and there were 3 deaths, and 2 of them were after stopping treatment and unrelated to the study drug. So I think this is interesting, and this speaks about the tolerability and efficacy of this combination. So in summary, we can see that this combination of linvoseltamab plus carfilzomib is feasible and safe, and the tolerability was consistent with any of these particular combination of drugs in monotherapy. There was only 1 DLT, and serious neutropenia and infections were the most common treatment emergent adverse events. In terms of responses, we have a 90% response rate and 76% CR rate, but with enough follow-up, I would say that virtually all patients achieved a CR, and the responses were durable with a PFS of 83% at 12 months. There were no difference between those patients that were exposed or refractory to a proteasome inhibitors in terms of responses. And I think these encouraging results are now being evaluated in an expansion cohort in this particular study, and also there is a registrational randomized phase 3 study testing this combination versus the standard of care that is planned and will start recruitment. And with that, I want to thank all my authors, all the patients that were included in the trials, and you for your attention.